adults and children with disabilities, seniors aging in place, and the professionals who support them. This is not a theoretical exercise. It's practical, rights-based path to a healthier, fairer Commonwealth. Our aim is simple: to ensure every person can participate fully, access the supports they need, and to do so in a climate of dignity and rights protections. I thank you so much for having me here today with you all. I walked around this morning and got to hear some of those lived stories, and it means a lot to me professionally and personally to be here with you all. So at the heart of the work lies a straightforward premise: health equity and civil rights belong together. Barriers, whether language barriers, confusing enrollment, uneven access, prevent people from getting the care and supports they deserve. A rights-based approach means designing services that are accessible, culturally competent, and accountable to the people they serve. Rights are not abstract. They are the compass by which we steer policy, partnership, and performance. Families navigate a system that includes special education, mental health supports, child welfare, housing, and transportation. In rural areas, distance, provider shortages, and transportation gaps magnify every challenge. So we need to design with those realities in mind. A clear, compassionate path that keeps everyone moving forward. Access that works for every child. Language access, disability accommodations, and consent that is meaningful and from the start. People first in design, the voices of parents, guardians, and especially the children themselves should shape how programs are built, tested, and refined. Schools, clinics, disability services, faith groups, and community organizations must work together while protecting privacy and dignity. Next, measures with meaning. Dashboards matter, but the stories behind the numbers matter more. We listen to lived experiences to know what's working and what isn't. Data should improve lives without exposing people to risk. Clear consent, confidentiality, and transparent governance are essential. Today, the panel will explore specific policy options and implementation details. We also intend to listen. Listening contributes to the framework that should guide every decision. The questions that you raise function, excuse me. The questions that you raise function as the internal compass, informing how we measure success, what we value in partnership, and how we hold ourselves accountable for the people we serve. Together, we'll explore: 1, effective policies and practices that reduce disparities, emphasize equity-centered design, inclusion, and accountability, highlight the importance of community input, language access, and disability accommodations from day one, stress transparent data use and safeguarding privacy while tracking progress. 2, systemic changes needed for equitable access, high-level, rights-informed reforms. Integrated patient-centered care pathways, streamlined eligibility and enrollment, robust cross-sector collaboration, a diversified workplace, and partnerships that anchor care in communities. We will talk about common factors driving disparities, social determinants of health, geographic variation, fragmented services, language and cultural barriers, and trust deficits. How rights protections can mitigate these factors by ensuring access, dignity, and participation. And public-private partnerships to reduce disparities. How collaborations can extend reach, improve quality, and share accountability. The role of community navigators, multilingual outreach, and privacy safeguards in partnerships. We'll draw on practical, relatable examples that illustrate what it means for families to experience timely mental health support, for children with disabilities to access inclusive education and services, for the elders to age in place with dignity. We'll also acknowledge the importance of faith-based and educational partnerships when they are grounded in non-discrimination, privacy, and cultural humility. The voices of families, parents, seeking clear guidance, kids who deserve a voice in their own care, grandparents who want to stay connected to their communities. These are not antidotes. They are the lived reality behind every policy choice. Centering these experiences helps us design systems that welcome people in, sustain their participation, and treat them with the respect they deserve. Today is an invitation to translate rights into daily practice. Let's commit to a Pennsylvania where every child has timely, respectful mental health support. Every family can navigate complex systems with clarity and kindness. Every rural elder can age in place with reliable local care. And every person can engage with agencies in an atmosphere of trust and privacy. Thank you for your attention and for your commitment to healthier, fairer systems. I look forward to the conversation and the concrete actions that we will follow, grounded in human-centered, rights-driven approaches that respect the dignity and potential of every person. At this time, I would like to introduce our panel. As I introduce you, please take your place at our table. Director Sarah Messina. She's the Director of Alcohol, Tobacco, and Other Drugs, ATOD, Prevention Child Guidance Resource Centers. Jennifer Jordan, Vice President, Care Continuum and Behavioral Health Strategy Hospital of Health System Association of Pennsylvania. Laura Sigmund Warner, Director of the Delaware County Health Department, and PA State Rep Lisa Borowski, State Representative of the 168th District. Would you like to wait for Senator? And circle him back in. We'll be welcoming Senator Tim Kearney when he arrives, and we can circle him back into the conversation. So I would pose our first question to State Rep Lisa Borowski and give everyone a chance to answer the question. After Lisa, after you finish your question, I'll direct it to the next panelist. So Rep Borowski, from your perspective, what are the most pressing barriers that prevent individuals and families from accessing affordable, quality health care?
Is it working? Well, thank you so much. Oh, here's Senator Kearney's coming right now. Well, thank you for the question, and thank you all very much for having me today. I really appreciate it. And thank you to all the professionals that are here sharing the information about the good work they're doing in the community. It is not easy to be in healthcare these days, so I admire you, I admire the work you do, and just want to thank you so much for what you're doing for our communities. So, as a state legislator, I've had the opportunity. Good morning, Senator. I've had the opportunity to not only see what is happening here in Delaware County, but what is happening across our Commonwealth when it comes to healthcare. And I would say that while here in Delaware County we are certainly experiencing some tremendous healthcare challenges, we are not unique. It is just, I think, a difference of location, a difference of accessibility, but certainly I think one of the biggest barriers is just having healthcare providers in areas where people can easily access them. That is the biggest barrier. I spent 30 years working in healthcare, not in direct patient care, which is good for patients. And then I grew up, my father's a physician, my mother's a nurse, so I guess I've been around healthcare my entire life. But I worked for Mercy Health System, so kind of right down the street. I was in Darby for about 15 years working there, and then worked at Einstein Healthcare Network in North Philadelphia, and for the network in Montgomery County as well. We've lost so many providers, and for me, I always say I came out of school in 89, started working in healthcare in 91, and a lot of the challenges that we were trying to address in 91 we're still trying to address today, which is disappointing, I'll say, and we haven't progressed very far, but we, at the time when I was active with community relations and things like that, we were trying to place providers in communities, in situations that made people comfortable to go and access the care. So do we have maternal child health services in a row home in the middle of the block that looks like a house that people are just going to seek care? Because that's more comfortable than going into a tertiary care hospital that looks big and scary and threatening. So those were the things we were doing back then. We have, I think, and healthcare is certainly cyclical, but we stepped away, I think, from some of that, like a lot of the health centers, like neighborhood-based health centers and things like that. Hospitals investing in that because they have seen, financial challenges that make that more difficult. We also we just don't see as many people entering the professions that we really need providers in. Pediatrics, family care, because why? The reimbursements aren't there. The money isn't there. If you've gone to school and you come out of school, I sat next to a pediatrician. She was in her final year of residency out at Penn State Hershey. I went out there for an event, the medical center out there. She finishing her pediatric residency, her fiance finishing his residency in internal medicine. They were going to both leave their residencies with almost $1 million in student debt between the two of them. How do you start a life like that? Like, how do you start anything like that with that kind of debt, that kind of burden? And she said to me, she's like, I probably should have picked a different profession, which is, bad. We need people to be pediatricians. We need family practice physicians. So a lot of the barriers, I think, is the lack of providers, the lack of the support that we're providing people to become providers in areas where we really, really need physicians.
Thank you so much. Yes, at this point, I would like to welcome Senator Timothy P. Kearney, PA State Senator from the 26th District. Thank you for joining us, Senator. To catch you up, if you're comfortable going next, I would repeat the question, not only for you, but for our other panelists as well. Excuse me. So from your perspective, Senator, what are the most pressing barriers that prevent individuals and families from accessing affordable, quality health care?
That's a big subject. Hello, everybody. Good morning. I'm sorry I'm late. It's petition time in politics, and so this is my third event today. Already. So it's good. I'm Tim Kearney. I represent the 26th District in the Senate of the Commonwealth of Pennsylvania, which includes all of Upper Darby, which I have always considered the beating heart and soul of my district. And a lot of that deals with what we sort of are trying to deal with at the scale of state oversight and state what we can literally do. To piggyback a little bit on what Lisa was talking about, the Department of Health right now considers Delaware County a health care desert, and specifically a maternal health care desert, and even more than that, a black maternal health. I don't know what's worse than the desert, but we have serious issues that we've been dealing with. I'm an architect. I had a 35-year career as an architect before I took an odd left turn to get involved in sort of statewide politics, and I never thought I'd be spending so much time on healthcare. But healthcare in Delaware County has really been our number one issue. I think that we've been struggling with. On the business end, we saw what a private equity company could do to a healthcare system when it came in, and they literally raped and pillaged and took whatever they could out of the system that was already, in 2016 when Prospect Medical Holdings bought the Crozier system, it was already a system in distress, and because of the kind of systemic nature of how we do healthcare, the Crozier was a high Medicaid, a high no payer system, where people were coming to the hospital seeking care without insurance. And until we do something fundamentally different about how we do that, our healthcare system is going to continue to be at risk for people who are able to come in and use healthcare for their own goals, as opposed to the reason everybody gets involved, everybody who's in healthcare gets involved in healthcare. So I think that the biggest issue literally that we have is the system that we have and the way that we provide healthcare for folks. And until we fundamentally do something different to change that, we're going to continue to struggle. We're going to continue to struggle on the margins. Currently, in the city of Chester, for example, there are no physicians who practice in the city of Chester. None. There's not a single medical office in the city. That's crazy, right? I mean, especially if you think about what Chester was. 50 years ago, every doctor had an office in Chester because that's where people went, kind of thing. And it's same with Camden over in New Jersey and the like. But now, unless a particular practice is doing something that's mostly geared towards private insurance and money, we're not seeing. There's no investment made in that. When the Crozier system imploded finally and went into bankruptcy court, the parts of the system that sold immediately were the outpatient surgical centers, because those are all things that were making money, and weren't dealing with the high Medicaid, high Medicare, and no insurance folks. So we're at the center of the crisis right now in the Commonwealth because of what Prospect did to us in terms of the closing down of 4 hospitals. And we're struggling now trying to figure out how we can get something open again. Because right now there's whole sections of the county. We're not really talking about EMS here today, but EMS, was a huge struggle for us in the state because we were trying to provide the resources that would allow some of the EMS to reopen or to figure out exactly how we were going to care for folks, because 52% of the acute care ambulances were all part of the Crozier system. And, oh, by the way, those vehicles, the ambulances, were in such bad shape that I think only 2 of them were able to be used after they left, because they had basically stripped everything of any value out of the ambulances, much in the same way they did with the hospitals. So all 4 hospitals were left in a situation where nobody could. We were hoping someone could just pop in and reopen. Well, that's not happening. We're struggling right now. We're making some good progress on Taylor Hospital. We're hoping that that's the one that probably will reopen, at least as an emergency room, the first, if we can get Mainline Health to feel comfortable about it and make it work. And the state, we put tens of millions of dollars into literally trying to keep the Crozier system open, because I've come to understand that hospitals are like sharks, and if they don't keep moving forward, they die. And that's literally what we've seen in healthcare. So on that happy note,
Thank you.
I appreciate the fact to be here, and I hope I'm learning stuff.
Well, thank you so much, Senator Kearney. VP Jordan, do you need me to repeat the question?
No, not at all. Because it's a simple one, right? Okay. So in both my work and my personal life, I think about behavioral health policy and access to behavioral health care. And I think about it from a statewide perspective. So one of the things that I truly believe as well is that the lack of providers is one of the biggest barriers. And I think that that is symptomatic of a chronic underfunding of a healthcare system. And it's funny, I was thinking, like, how does that work that we all feel like it's too expensive? And as patients and caregivers, it feels like we put all of our money into it, but yet still there needs to be more. And I think that what we've built is a system that's collective. But the way that we fund it is in a collective function. And that's why we have the outcomes we have. I can envision a system where if you're a family and you touch a provider in crisis, there's the next step waiting for you. And like that does not exist in many of our communities, and you all know that as well. I think that one of the biggest barriers that makes our system hard to navigate is the gaps in provider capacity. And I'm hoping that we can talk about ways that we can fill that in this panel.
Thank you so much. Director Warner.
Thank you. Yeah, and in public health, we talk a lot about hierarchy of needs, and I obviously echo everything about the provider issues that we're experiencing, and so acutely after Crozer's collapse. But it's the challenges related to housing, food security, and transportation. Those are the barriers that are just at root, affecting our families being able to even get to think about healthcare, and now trying to find healthcare in less places than they did before. So anything that we do that addresses those core issues will help, but they're huge. But then the other piece, again, as we rebuild this healthcare ecosystem, and we so appreciate all the efforts at the state level doing this, we have to be the voices for the unsexy, unprofitable care sectors, right? Exactly right. Primary care, pediatric care, women's health. Those are the ones that don't make money. Those are the ones we desperately need, and the barriers are there.
Thank you. Director Messina.
I get to follow all these answers now. No, I think everyone kind of handled the question very well. But I do think it's important to note that in Delaware County, we absolutely are in crisis right now. But we got to this crisis, we were here long before all of these healthcare systems shut down. We have, more than 10% of our population lives under the poverty line. About 50% is under the median income line. So the idea that people just had this blanket access to care at some point just really isn't there. People have always had a hard time finding culturally competent care. The ability to find providers that speak their native language. Not everyone's an English speaker, and you might be able to get Spanish as a choice on some lines, but that's pretty much it, right? And just in general, healthcare itself is a very complex system. So it's not just the cost of getting insurance or the cost of paying your copay. It's also knowing what costs you're walking into when you get in there, what referrals you need, where to start. And I think Jennifer hit that point that people don't know where to start, so they don't start until there's a crisis. And then we're sort of trying to building blocks back around them, and it's not, we've already sort of let all the pieces fall.
Thank you so much. So, building on that, many people experience healthcare differently based on income, race, age, language, or location. How are these disparities showing up locally, and what steps are being taken to address them? We could start anywhere. I don't know if you still have. Director Warner?
I have the mic, and I might as well start at least with a little bit with some 3 data points on the disparities issue that I wanted to make sure I shouted out. Infant mortality is something that we know we're still seeing a concern here in the county. In the Pennsylvania-wide, black-white infant mortality rates actually narrowed, got better at the state level, but they got worse in Delaware County in our more recent analyses, and that's very alarming. And black infant mortality in Delco went from 3 times worse than white moms. Then it went to to white children. It went to 4 times the white rate. This is just not acceptable. We have discrepancies in breast cancer mortality in black women versus white women. Again, this is despite similar screening rates. And this highlights gaps in early detection, follow-up care, treatment access. We see differences in blood lead poisoning in our children that are continuing. We're doing a great job now that we're here to be able to increase screening for blood lead elevations in the county. But as we see more children that are poisoned, we're seeing that we need more resources to address that. And so those are the 3 disparity areas I wanted to highlight. I guess, do you want to keep going? Let everybody have a chance on that, or then we moving into solutions? What do you want?
That we could give everyone a chance if you want to pass the mic. Anybody volunteer? If anyone else would like to say.
Can you say the question just so?
Absolutely, no problem. So many people experience healthcare differently based on income, race, age, language, or location. How are these disparities showing up locally, and what steps are being taken to address them?
Okay, well, so Laura and I basically had the same answer. But I think, I was going to kind of go down the same road with the, we have a lot of infants, and in our county, we have a very high rate of infants in our county that are born with a low birth weight. And low birth weight infants it's tragic, right? They enter the world and they're already needing access to constant care. They need great health care from the beginning. But also what that shows us is that their mothers are not getting good prenatal care either. Oftentimes that low birth weight or whatever happens comes from the fact that their mother might have hypertension or diabetes or something else that they needed to get good care for prenatally, and they didn't have access to it. And those challenges stem from, again, lack of culturally competent care. In the Black community, there's not always very welcoming, warm care that if you can even find providers that look like you or understand what you're going through. So it's really challenging. I think in Delaware County especially, there's no one there right now. So,
Thank you.
I want to come back to when we were talking about solutions.
Oh, okay. Oh, you have the solutions? All right, we definitely want to hear from you on that. So, I guess what I'll say is, some of this and listening to the, you guys who are on the front lines of this, and having, been, I'll say I was healthcare adjacent, where, I worked in community relations and public relations and marketing and stuff like that. So I did a lot of work in the communities when I was working in healthcare. And now that I'm on the legislative side, I think some of this is definitely our fault as legislators. And in the 3 years that I've been in this role, I think unfunded mandates that we all sit around, and so I'm going to just refer to the lead. So, we've got some lead legislation around lead testing. That'll be great if we pass that, but where's the funds to support that? There you go. So where are the funds to support that? We could pass legislation all day long. Well, maybe not all day long, but we do pass legislation, but in the House we do. Sorry, Senator. But we don't back that up in many cases with the financial support. How do we support that financially? We know we need to do these things, but we need to commit to the funding to help the people who are the boots on the ground doing this really important work. How do we make sure that they are receiving the funding that they need? And I don't think we do a good job of that at the state level. That is where we have our biggest disagreements, I would think. And to me, when it comes to investing in healthcare for our communities, that is something we should all be able to agree on. So I think sometimes the legislature, as much as we will try to fix things as best we can, given the Senate that we have, Sorry. But no, as much as we try to fix things, we all really need to come together and say investing in healthcare is important. And we think that from the very top all the way down, filtering down to the people that are actually doing the real work.
Thank you, Lisa. Part of the problem is this, that most of the systemic issues around healthcare are not just about healthcare. They're literally about the way we've structured our society and the way it works. So everything, it's all related, from the way we pay for public education, right on through to healthcare. So what everybody's saying, we understand exactly those statistics you're talking about. The fact that there's only one hospital in Delaware County right now that has an obstetrics unit speaks volumes. The birthing center in Bryn Mawr is just closed, which is a huge loss for us, and especially in terms of natural births and doula work and the like. All those things are just contributing to what's a much larger problem all the way across the board. And we've spent the last 50 to 60, 70 years building up this system, literally starting from the GI Bill back after World War II, which we really got into mortgages and home ownership and and highway systems and the like and all those things. I mean, it's daunting sometimes to sit in our seats and try to understand that whole the depth and breadth of the whole problem. And it's very difficult to solve the healthcare piece when you're not going to solve the education piece, when you're not going to solve the public assistance piece, when you're not going to solve, and transportation, absolutely. I usually wear my SEPTA pin with me. I didn't have it on today, but that was. So I think I'll end it there and go to Jennifer for solutions.
Yeah, Jennifer's gonna
The pressure's on BP.
Yeah, no, I think that everyone is speaking to the underlying structural racism that really shapes the world that we live in, and healthcare is definitely impacted in that too. I got the privilege for 3 years of convening hospitals and health systems across the state. They're equity champions within those systems who are really thinking about how to have different outcomes, at least once patients touch the healthcare system. Those folks within health systems were trying to retool a system that wasn't really built for equitable outcomes to produce some equitable outcomes. And I think that the systems that actually engaged patients, caregivers, folks with lived experience in looking at the data and trying to find solutions, those were the ones that moved the needle. I think it's very easy, especially at the statewide level and even the local level, to look at the numbers and think that you actually understand what's going on. And it takes actually talking to people whose lives are represented in the numbers to really understand the nuances of how things are happening on the ground. So it was interesting in this collaborative to see organizations that just put money on top of the thing that they were doing wrong and doubled down on it, and those who actually listened and realized that part of their solution around some of their birth outcomes was to change the menu for birthing parents, to have some culturally relevant foods. Not everything is going to be that simple, but listening and being able to actually understand the experience is fundamental to solving both policy issues and also on the ground kind of care delivery issues. And that makes me hopeful. That doesn't always take new money. It takes a new way of decision making and solution building, which is inclusive.
Beautifully stated.
And having those equity officers in hospital systems, I mean, what an amazing thing, right? So we're doing something right now in the health department. We're working with the equity group at Mainline Health, again, to address this issue of breast cancer screening and cancer follow-up. And we're also partnering with Jefferson to, we have, and I know other folks here have done this, where we can bring the mobile mammogram. It was in Chester with some of my staff yesterday. We can do screenings in Chester or in Upper Darby, but then the follow-up care, where is it and how do they get to it? If you're staying with Jeff, you're coming back down to Philly, and how hard is that, right? But with Mainline Health, we're now they're going to participate in some of our focus groups with these at-risk moms, exactly the ones that have had bad issues, bad outcomes with breast cancer, and listen to them. And that wouldn't happen if they didn't have that program embedded and they were listening to the data that they have and helping us work on it. So.
I agree. I work in prevention, so I'm gonna come from this from a prevention perspective. I also think, when we're thinking about solutions, it's the idea that we have to start. We got to go back, and we have to start early. Families need support. It's hard to raise a healthy family when you are struggling with housing and you're struggling with food security and your neighborhood is unsafe and all of those other things when there's no grocery store in your local community. So I think we also need to think about the fact that we need to restructure our healthcare system, absolutely, but as a society, we also need to go all the way back and protect our families by starting and preventing them from even getting to the point where they need all of this healthcare. A lot of this is preventative, and if we put in a really great system of prevention and support for families, we can hopefully take some stress off the healthcare system, which would be really nice.
Thank you.
You have a solution, Tim?
No, just no. I mean, it's the problem on the state level, of course, is that the kinds of things we're talking about requires investments. It requires the idea that we would spend money on things that we don't necessarily have to, but that will have great outcomes in the future. And that every time we go into the budget discussions in Harrisburg, it's crisis management. And so we put Band-Aids on things and hope that they'll somehow miraculously get better. I mean, I think a great example of this is for the past several years, we've been carrying a very large surplus in the state budget, tens of billions of dollars, a little over $10 billion. That money, literally, it's important to understand where that money came from and why we had it and what we should do with it. During the pandemic, the federal government sent out checks directly to people, directly to folks. Remember getting those? Everybody remember getting one of those checks? And the difference between that and other sorts of things that the government often does is that those people, when they got that money, they didn't sock it away in an IRA. They didn't put it in a health saving in any kind of accounts or whatever. They spent it, right? They went out to dinner. They sent their kids to karate lessons. They did all these other kinds of things. And what that did was that money stayed local. And it went to businesses, and then those people spent it, and then those people spent it, and it circulated. The money literally circulated. Every time the money circulated, the state got a cut on it on sales tax. So we had, I believe it was 9 quarters in a row of higher than expected revenue coming into the Commonwealth, and you can really trace it back to that, because what we're seeing right now, what we're hearing about, mostly from folks on the other side of the aisle, is that we have a structural deficit within the budget in the state, and we're spending $3 billion more than we're bringing in every year. And most of that money is in what people call entitlements, and that's money that we have to spend. That goes out to folks. A lot of it in the Health and Human Services. That's the largest part of the state budget. So. I think the solution on the state level is going to have to come from an understanding that we can make investments in people and that those investments will pay off, as opposed to cutting taxes the way we're doing it on the federal level. We're witnessing the largest transfer of wealth in the history of the country, and it's from the lowest denominator to the highest denominator in our systems. And I think almost everybody can understand that trickle-down stuff doesn't work. And I think the Pennsylvania issue with the federal money in our budget surplus indicates that trickle-up actually works really well. And it works for us as a society when you care about the us as opposed to the me. So I'm full of joy today, aren't I?
Thank you, Senator. Rep. Borowski, do you
Well, I
add
guess I'll
anything?
I'll be really quick on the solutions. I think some of it is, definitely the data, understanding the data and health systems really looking at that and outside the box thinking. I know when I was up at Einstein, one of the things that we did was to try to address that prevention piece. So people who had ongoing chronic conditions, we partnered with Burholm Ambulance, and we did a community paramedicine program. And the paramedics used to go out, the EMTs, and they would go out and they would do well checks. They would do blood pressure checks. They would monitor heart rates and things like that. And a lot of that was to prevent people from having to come into the emergency room, which is the most expensive place to seek care. For a primary care issue, because a lot of these people, a lot of communities, they don't have access to a primary care physician, or to get to their primary care physician, it is a challenge. So we were doing going to people. So meeting people. People who say this, I'm always like, oh, but meeting people where they need to be met. What can we do to create those programs, and how can we make that something that is, as much as you hate to say it, is a benefit to the hospital, so they don't see it as a drain on resources. Because definitely it's easier to, a little easier to staff an emergency department, just wait for people to come to you. It's definitely more of an effort and an investment to take programs like that out on the road. But what's the end result? Is the end result people being cared for in their own homes, people being cared for, and problems being identified early, before they need to come to the most expensive place to seek care, which is an emergency department. So I think the more that we can do that, and make it worthwhile for our hospitals, our health systems to figure things out like that, then I think those are some of the solutions that can be very successful, and hopefully invest in them so they can continue to do them. A lot of these programs start and then they are ended. So because they just don't, they're not revenue drivers, and sadly that becomes a main issue.
Thank you. So, next question is, for the underinsured or the uninsured, what challenges do they face in getting preventative care or managing ongoing health needs? And how can policy better close those gaps?
I think we all are so deeply aware of the crisis for our underinsured and uninsured populations right now, and we can't comment on that without bringing up the challenges for our undocumented families and what it means in this climate of fear for them to even try to access health care, let alone pay for the health care that they need. I'm grateful as a health department that here now that we can serve and provide at least some very important health care for those populations, with at least vaccinations, STI testing and treatment, and tuberculosis treatment. But this isn't all that they need. There's so much more that everybody needs in those populations, and I just know there's a lot of gaps there. And I just want to echo what Rep. Borowski was just saying about community paramedicine. I think that model is huge and important. And I was just on the phone with our EMS council president for the county this week, talking about these different options that are out there that are like community paramedicine, where the 911 center can triage a call to a board certified emergency physician that will do it by video conference with the person, and then and then you can determine and get care that way. And then there's follow-up care too after that. I mean, but these are expensive and they need to be sustaining. And but it gets care to people in their homes, and you structure it so you can also cover the uninsured and the underinsured. And that's when it's successful.
Thank you.
I think, like we said, there's the obvious, which is just the cost. Preventative care, if you're uninsured or underinsured, is expensive. And for a lot of our families, like we said, it's competing with other things in their lives. You're not going to go pay out of pocket to get a physical and some blood work when you need to pay your rent and put food on the table, or your child needs care. Parents especially, grandparents, things, they sideline their own health needs or preventative needs for the sake of what they can afford for their family. We also get into things like people being able to take time off to get to preventative care and things like that. There's a lot that goes into that, and when you have to pay for it, when it's not easily accessible, it just is, I think, one of the first things that people just don't get to, and they just can't.
Part of what I've been thinking about, like in this moment, is both the hopeful and the terrible piece. I feel like we think about healthcare services and access and preventative care, putting folks who need those services into buckets. So there's uninsured, there's underinsured. And I think that we're at a moment, in especially the federal climate and what we may or may not do at the state level to counteract some of the cuts that we're seeing, that we're all going to be in the same bucket. Like the infrastructure that folks who are uninsured and underinsured need are going to be the infrastructure that folks with commercial insurance need. Like we all use the same services, we all need the same system, and when that system is under threat because of loss of coverage, it is no longer available for anyone. And I feel like if we can start to like get there where we think this is a collective infrastructure and we all need it, the way that we respond and push back to bad policy is different. Like we do it collectively. We don't just think about saving Medicaid or like trying to, we think about trying to build something that serves the needs of everyone. And I think that is where we're headed. When you look at the federal budget and like some of the cuts and programs, like it's so significant that everyone is going to feel it, regardless of who your payer is, regardless of whether or not you're insured through your employer or through a public system. Like we're all going to miss out on the things that we need. And I think that we have to start to internalize that and respond to it before it's too late. Sorry, I'm like such an alarmist. I'm often on the phone with my colleagues and they're just talking about the numbers of people who have already dropped the state marketplace insurance penny, and I pause. I'm like, are you afraid for yourself? Because I think that we should all be afraid. Like these providers aren't going to be able to serve like a smaller population. They're built for scale. They're built with margins that are already extremely thin or in the red, and we can't expect the system to be able to absorb the sort of loss in coverage and the loss of funding without constricting. And you all know that. Like you're sitting in a place that's already seen that sort of provider loss. Please tell folks in the rest of the state that we should care about this for all of us.
Yeah, you're absolutely right. You know, in my communities, the message that I've been trying to say, you may say, oh, well, I'm not on the ACA. This isn't going to impact me. Yes, it is. It is going to impact you. So, remember I said, so I harken back to like 1991 when I first started in healthcare, and I worked for the Sisters of Mercy, and the Sisters of Mercy, anyone who came, they would take care of you regardless of your ability to pay. And that was our tagline. That was one of our taglines. And we would talk about uninsured and underinsured. And for a long time that went away. I mean, with the advent of the ACA and people being able to get insurance, people having access to care that maybe they didn't have, that wasn't as huge an issue. I mean, it still continues, it does still continue to be an issue, but not as great as it had been. And then it was really like, why is the Medicaid reimbursement so low? So that was a whole other story too. But now, like, we're right back where we were. Like, to say those things, like, I hadn't heard those words. You haven't heard those words in a long time. It's really, I think, disappointing. It's like we don't learn from our own mistakes, right? We don't learn from our own mistakes, and that is, that's really challenging. I worry so much about that. So I'm a member of the Black Maternal Health Caucus. I'm going to give a shout out to my colleague, Gina Curry, Representative Gina Curry, who represents this area. She's fantastic and fabulous. She is one of the leaders of the Black Maternal Health Caucus. And she and her, Latasha Mays, who's state rep from Allegheny, and Morgan Cephas, who is in Philly, they're the leaders. They are drilling this into everyone's heads, and certainly the impact, talked about the gross disparities between births for white women and black moms. It's just that it's stunning, and it's horrible when you think about where we are. I mean, this is 2026, right? We should be getting better, and it's not. So I hope that our federal government, sadly, are going to learn what a bad decision they've made, what a bad decision this has been, that all of the doomsday predictions that they were ignored or felt it was more important to do what they needed to do are really going to hurt people. And it's hopefully they'll reverse course. That is my hope.
So a couple things. I mean, I think in terms of understanding care and how it's accessed by people, if you take a look at the data for the number of people who went to Crozier, to the emergency room there, and then you look at the increases we see at Riddle with Mainline Health and with Mercy Fitz, they don't add up. And I should point out that at both Riddle and Mercy Fitz, they're doing incredible work with the influx of new patients that they weren't expecting or they weren't designed for or built for. The amount of work, the things that they're doing is really amazing. That being said, there's so many more people who were getting services at Crozier who are just not in the system anywhere. They're just not seeking care. And I appreciate that Laura brought up the undocumented folks. Undocumented folks they're not even going to the grocery store or letting their kids go to school. I mean, they're certainly not going for health checkups or the like. So I mean, the things that we're seeing out of the federal government, particularly with ICE and the way that they're working, is really. I mean, it's I hate to say icing on the cake, but it's really kind of it's very difficult to deal with. Among other committees in the Senate, I sit on the Appropriations Committee. So we're, obviously very much, we're in the middle of budget hearings right now, trying to figure out how the money stuff is going to work. In the big, beautiful bill that passed last year, the H.R. 1, in 2027, we in the state will be looking at a $10 billion hole in our budget from money that we were expecting from the federal government to come to the state. Almost half of the money that it's in our budget comes from the federal government, and it passes through the state government in order to get up to where it's needed. But a $10 billion hole, there's nothing the state could do to try to remedy that or to try to fill that. So it's staring us in the face. It's all very purposely meant to happen after the midterm elections this year, and it'll be, I consider it part of the federal government's war on the poor. We don't have a war on poverty. We have a war on the poor, and it's and what we're seeing. I talked about the transfer of wealth earlier. What we're seeing, it's all very consistent, and it's all exactly what they said they were going to do, and it's exactly what we're trying to deal with.
Thank you.
I would expand to recast it. It's not just a war on the poor, right? It's the war on anyone who isn't uber wealthy, right? When you're thinking about who's losing. Yeah. We should all own it, because unless you're ready to go and pay out of pocket for what you need somewhere else because it won't exist in your community, it's a war on all of us.
Thank you, VP Jordan. So, Director Warner.
I know that we had only got through some of the questions, but we've covered a lot of overlapping. And do we need to have Q&A at this point, or what do you think?
We have a few more questions, and we can go to Q&A. Community-based health and mental providers are often the first point of care. What challenges do these providers face due to the limited or inconsistent funding, and how can legislation help sustain these essential services? Who would like to start?
we keep circling the same question about how do we pay for what we need. I look at behavioral health care, community-based services, and hospital-based services, and workforce is a huge challenge. I think that sometimes we say workforce like it's a clean box and it's just the people aren't there, but I truly believe that folks do jobs that are rewarding and pay them. And it's fundamentally a funding question. And it's definitely prevalent, especially in the community-based services world, and you all know that. So again, we're circling back on how do we pay for the system that we need.
Thank you.
So I will just say, if legislation is the answer, that can't be the answer. Mainly because, and the senator and I kid around about this, but because we're on the same page on all this stuff. It is not easy right now in the current legislative body that we have to get any real, I think, meaningful legislation passed to address these issues. The senator and I have a bill that we've spilled a lot of blood, sweat, and tears over. And it started out as something very strong, something that we felt could really make a difference in healthcare, based on what we've seen happen with the Crozier Health System. And if we get it passed, it will be a shadow of itself, and some of that is because there's so many stakeholder voices that I think in some cases are afraid to stand up and say, we just really care about patients, and we need to make this about patients and providers and not as much about, certainly we want our health systems and our nursing homes and those facilities to survive, but it can't be about like our profit. What will the profit be? Like, unless it's profit that's going back into the system and going back into that care. So we need more people to, I think, stand up and say, we need to be here for patients. We're going to pass legislation that is about patients and about providers providing care, as opposed to being afraid of, what that could mean or impact the bottom line. I'm trying to be politically.
I might not be, but so Lisa kind of hinted around the edges about this. What we're talking about is a healthcare oversight bill, which would essentially give the Attorney General standing to review any large scale dollar transaction that occurs within the healthcare system, and that's really based on after after dealing with Prospect, who I always thought was very aptly named Prospect, in terms of, we determined that anytime there was a large scale, and we started with a $10 million number, transaction that occurred within the healthcare system, invariably 2 years later something terrible happened in terms of the way it was set up and the way it works. Part of the watering down that Lisa's talking about is I think the number's now at 25 million. And the latest sort of five-party talks, five parties as in the four caucuses within the House and the Senate and the governor's office, we're going to have to take nursing homes out of the bill at a time when Genesis Healthcare, the largest nursing home operator in the country and the largest in Pennsylvania, declared bankruptcy a month ago. And we saw the issues with the nursing home in Bucks County, where there was the gas explosion, which there's a lot of finger pointing going on with that, but it really does come down to how the building was staffed and how it was maintained, and a lot of that tends to happen when you have private equity who are in positions where they're controlling the dollars and how the dollars work. So the sort of the semi-ironic thing about all this is that our bill, Lisa's and mine, is not really going to help Delaware County because that ship has already sailed. We were already been screwed, and somehow we're trying to claw our way back. The the hospitals that I think are most in the sort of crosshairs of the private equity playbook are the rural hospitals. I mean, rural hospitals across the Commonwealth literally have the tightest margins. They have the highest percentage of Medicaid, Medicare patients, and they also have, when they close down, you know, like for our ambulance rides are increased by like 45 minutes to an hour based on where they're trying to get to. But if a rural hospital closes down, that could be 2 or 3 hours to get to the next closest. And the same people who represent the people who live in those areas are the people who are causing us to water this bill down even further and further, and it's insanely frustrating. I tell people I have a flat spot on my head right here from banging it against the wall in Harrisburg. But we're going to continue this fight, and we're going to continue to advocate for things that help all of Pennsylvania, not specifically our district, which you hear that a lot in Harrisburg. Well, I'm just voting my district kind of thing. And we're healthcare in particular, and we talked about this earlier, the fact that it's not just healthcare, it's everything else too, and it's the societal systems that we have that we're arguing need to change. And very often we always thought that the financial thing would work, the financial argument would work, but it doesn't. And so that being said, I'm doing this again. We're going to continue, and I'm going to, still try to be a voice in Harrisburg and try to make things. Yeah.
Thank you. Director Messina, did you want to comment? Okay. So, how can partnerships between legislators, community leaders, and local organizations be strengthened to improve trust, access, and outcomes?
I think it's going to be one of the ones we agree on across the board, but partnerships help have consistent intentional discussions about shared goals. It's driving everybody in the same direction to try to maximize what we can accomplish. And I know as a health department we do that through our community health improvement plan and partnering across the board, a lot of people in this room, and I think that's probably
I totally agree. I think just, opening the lines of communication. I also think adding supports in there for individuals to be able to access all of us. Oftentimes we're all sitting here, we're all working on it, but none of us are necessarily working together. And I think individuals feel that as well. So finding places where they can get care coordinators or case managers and people who can actually help them access the gamut of systems and understand that they all work together, and their goal is the individual and the well-being of the individual will build that trust and that feeling that this healthcare system is there to help them and support them.
Thank you.
Sure. I think that there is no one solution to any of these complex problems, and moving things forward takes everyone's participation. I'm thinking about organizations that hold data about the patients and the families that you're serving, and how no one in Harrisburg understands that dynamic until you tell them. I'm thinking about folks who've experienced healthcare in a certain way, and no one knows your experience until you say something. I think that there's a huge opportunity for storytelling and for participation that we often miss, but is needed to solve the problems that we're facing.
Thank you.
I would definitely say, just being at an event like this and having the opportunity to, interact and talk with people who are really doing a lot of the work. We do have, many of those opportunities do present themselves. The county does a lot of that, engaging us as legislators. And legislators, I think, also, they include, the county level legislators and local as well, local legislators. But, I agree with the storytelling piece. It is far more easier to tell the story when you actually have case studies. And as you can see, I love to tell stories about the things that I've experienced when I worked in healthcare, the things that, we saw work, the things that I am so sad about that no longer exist. I guess that's just because I'm old, and I've seen a lot, but it's that is important to me, and to really hear from the people that are being directly impacted. And we've had a lot of opportunity of that, especially with the loss of Crozier, to hear from people. So that is really important. But we need your voices to help us talk to our colleagues. Senator Carney says he's got like a flat part on his head. People get sick of listening to me. It is so good when you hear directly from the providers, when people are calling your offices, when you are hearing from patients, when you're hearing directly from the people who are being impacted by the decisions that we're making. A lot of times there seems like there's a lot of distance between what we're doing. Everyone thinks like I live in Harrisburg now, which I don't, but we're in Harrisburg a lot, but we are in the district, we are here, we have staff in the districts. Like, people need to be talking to us, reaching out. Encourage your clients, your patients, everyone, that if there's something that's important to you all, please share that with them and have them call us, because that is where the impact is being made. And maybe it's not, sometimes, down here in Delaware County, I would say are the majority of our, our Senate delegation and our representative delegation, we're with you. We're on the same page with you, and we are fighting for a lot of this stuff. But as Senator Carney mentioned, it is leadership in the Senate. It is other Senate leaders. It is colleagues of mine in the House. So it may not hold as much weight with people because they're like, oh, that's not my constituent, but it still matters. Like, you should still reach out. You still need to call. So that is what I would ask when it comes to partnership on some of these things to get things done.
Thank you, Lisa. And I echo everything that she said. I think it's important for us to maybe look at a bright spot in all this. And I think the brightest thing that's happened in healthcare in Delaware County is the establishment of the county health department. And they, I was part of the group that, approached and negotiated with Chester County during the pandemic, where we literally got the Chester County Health Department to basically serve Delaware County at the same time. That never happened before, and won't happen again, I don't think. But it doesn't have to, because county and state delegation folks, even the congressional people, got together to really underscore the importance and what it means. That the pandemic really showed why it was so important to have a local health department and what it could mean for the health and well-being of everybody in the county. So that was, to me, that's a tremendous bright spot that we were able to do it and get it set up, and the health department's doing a wonderful job, not only from keeping people healthy and doing preventative work and providing clinics, et cetera, but they're working on policy as well. They're helping us understand what can happen and where the rubber meets the road, and when we can literally do things in Harrisburg. Because I agree that personal stories and communication it's all key. But as Lisa said, our delegation is kind of there already, and the problems that we're running into and pushing against are, there's a huge thing in Harrisburg where people hate Philadelphia. They think Philadelphia is just a place where money goes to, they waste money by sending it to Philadelphia. And then we point out the fact that, for example, the SEPTA, we were talking about transit earlier, the SEPTA system covers less than 10% of the land mass of the Commonwealth, but it provides 45% of the revenue that comes into to Harrisburg. If you think about that, that's, my friends and colleagues tend to like to call me a socialist, and I always say, well, no, actually, you're the socialist, because you're the ones who are taking so much more out of Harrisburg than you're contributing. And we're quite happy here in Delaware County and the Philadelphia region to pull more than our share in order, because we understand the basic meaning of the word Commonwealth and what it means for the people. So hopefully that's something a little bit positive we can dwell on as part of it.
Thank you so much, Senator. Right now, I'd like to ask our final question, and to keep that in mind while we're answering, so we have a little bit of time left for Q&A. So, what concrete commitments or policy actions can be taken to ensure healthcare equity remains a long-term priority for our communities? That'd be fine.
We have to continue to really support our federally qualified health centers and anything that has low barrier or access to our primary care and behavioral health care. I mean, that to me is my one of my biggest ones. But that feeds into all the things we were just talking about community paramedicine and other ways to be able to help people get access in their communities, as well as, I keep going back to transportation, get them elsewhere when the care has moved. How do we get them there? So
No, completely agree. I also think we just need to keep talking to our communities and keep having moments like this, but also like continually asking people what they need, what they're missing, how we can help, how we can do better, and just keep talking about the funding and how to make it equitable and accessible to everyone.
I automatically go back to funding. We need to be prepared and to pay for the things that we know are helpful in our communities. And to hold two conversations at the same time, both like what Band-Aids do we need right now? I'm thinking about like the crisis services infrastructure that families rely on when they're in behavioral health crisis, and how that's underfunded and inconsistent community to community. So that's a solution for right now. As we continue to talk about how do we fund preventative care, integrative care, so we don't need the crisis. But we have to do both. We have to have people who are thinking about the big picture and where we want to be, and kind of stringing together what we need right now.
So, I can say, certainly as Senator Carney and I sit in front of you, we're committed to making sure what happened at Crozier doesn't happen anywhere else. That's definitely a concrete commitment, I think. We're doing everything we can to do that. I'm willing to sell my firstborn child too, if that needs to happen. No. He may not. Yeah, he's an adult. He's an adult. I know. Just kidding. I could rent him out. He's an attorney. I could rent him out. But I think there's definitely a commitment there. And Senator Carney's seen it for a lot longer than I have, because he's been around, sadly, to watch the demise. But I think that that's definitely a commitment from a legislative perspective in this moment. Policy actions. For me, there's several things that we've been looking at, but as I have been harping on, I really believe that we need to be supporting our providers. So whether that's looking at our nursing schools and how are we getting more nurses into the system, how are we addressing the issues of preceptors in hospitals, because we can have nurses go all through nursing school, but if there's no one there to train them on the floors, then then they're not getting the care, they're not getting the experience that they need. So then we're not getting good trained nurses. So we're talking about nursing, if we're talking about other medical professionals, so physicians, physician assistants. We have several pieces of legislation around the compact. So how can we, I just signed on to one for a respiratory therapist compact. There's one out there for nurse practitioners. There's one for speech therapists. How do we make it easier for people to come to Pennsylvania and practice? Right now, it is not very easy. We don't make it easy. So what kinds of, how can we look at that legislation and try to move that legislation and make people understand how that will make a difference? So I think definitely a commitment there. And then I really think that we need to have a serious conversation. And I think all of us, I would say, like right now, healthcare, it's like a game of whack-a-mole. Like you think you hit one, you're like, oh, we're going to fix this thing, and then something else pops up. And I think we've demonstrated that here as a panel. But, how do we make it more attractive, more affordable, and more, put the respect, I think, back into the medical and healthcare professions that I think we've lost a little bit of, so that people want to go into those. They want to go into those professions. They see it as something that can actually do and make a living, have a life that that they want to have, and we can get more providers to help with these shortages that we have, whether it's in our urban communities or our rural communities or suburban. So that is a commitment, I think, a policy action that we can probably have a more comprehensive conversation about.
I hope that, I think that what everybody can take away from this panel and everything else that we're hearing today is the fact that everything's interconnected, and that we have and certainly in Harrisburg, we try to put things in silos, we try to put things in boxes and deal with them individually, and the reality of it is that you can't, because everything is interwoven and interconnected in ways that don't really become obvious until you literally start to dig into the details about trying to sort things out. We need activists. We need people who are willing to write letters, to make phone calls. We need people who are willing to, when the time's appropriate, to go out in the streets and yell. It's a system-wide problem that we need to solve, and it's not going to be solved. We can't just solve healthcare. We can't just solve transportation. We can't just solve all these various things. There's going to be a butterfly effect thing. You do something over here, something else happens over there, and trying to sort that out in the context of a budget. Because let's face it, that's what the state government really does: is control the budget and make the sort of what I consider moralistic decisions about what gets funded and what doesn't get funded, and where we can put resources and where we can't. Pennsylvania, we used to be leaders on some things. Back in 1993, we passed the first CHIP program in the country, which was health insurance for kids. Think about it. And I don't want to get political, but the other party basically said, that's crazy, we should get rid of that as soon as they got back in power again, they tried to get rid of it, and they couldn't, because it was such a successful program, and it became a national program like a year later, a year and a half after Pennsylvania passed it. We got to get back to a point where Pennsylvania can be leaders again, and we're never going to be leaders again until we really fundamentally understand that it's investments in people. The CHIP program is an investment in our society, an investment in our kids. And that's where we need to get to, and that's and quite frankly, for us to make that change in Pennsylvania, we need everybody on board. So thank you.
Thank you. So at this time, we have a few minutes for questions. We want to hear from you. Does anybody have any questions for the panel or for any panelists in particular?
So I'm a physical therapist, and one of the issues that we've run into is not, it's more than just like underinsured or insured people, but it's the people that have Medicaid that we're trying to treat them, and they're calling it a closed panel for Keystone First, which is the primary Medicaid insurance in the Philadelphia Delco area, and we just can't even treat those people. What do you suggest in terms of political, how do you combat that when you can't even when you're a facility, you can't even treat the patients that want to be treated, even though the reimbursement is really low?
Just real quick, we talk about how everything's related and interwoven and everything else. The people that we tend to have the most disagreements with and arguments with are insurance people in the Commonwealth. I mean, it's a fact. I mean, I don't care what the issue is, we always seem to run into issues with the insurance. Even the hospital bill that we're talking about, trying to get the insurance folks on board is difficult. Everybody's very protective of kind of what they have, and there's we are constantly dealing with accusations of kind of waste, fraud, and abuse, and what that kind of means to the systems, and how people think that by narrowing that narrowing the field as to what they'll accept or what they won't accept is something that they think is fundamental in just the system even remaining afloat. So I don't have a good answer for you other than to say we got to change a bunch of things, and that's certainly one of them.
Yeah, I don't know how we address a closed panel. I would say, so you guys can't get on the panel, is that what it is?
Yeah, like
So-
we're like considered like out of network, and like we have applied, and they're just basically like, no, we're closed, and like we can't even get in network with,
Where are you guys located?
we're in Havertown.
In Havertown? I mean, sometimes, we as we have legislative liaisons with the various insurance companies. If you want to call my office, maybe we can reach out and talk to them. I mean, I don't know how we would open a panel if a panel is closed, but we can certainly have a conversation with them and see if there's something that we can do. So
Yeah, I think it just it's a bigger issue, beyond just our clinic, but like if there like a lot of the hospital systems don't even take Medicaid because the reimbursement's so low, and then when that you actually have a facility that actually wants to take those patients, we can't even do that without doing a pro bono.
And that is, so I actually have a piece of legislation that we're working on. We haven't introduced it yet, but it's to expand PT, OT, and speech therapy for under 21, so children under 21 who need those services, so that because so many are sitting on a waiting list because the providers are inaccessible. So how do we expand that to more providers? So we do have legislation. We're working on that. It is not going to be easy legislation to move forward. Again, because of the insurance providers, I think are not going to be thrilled. But sometimes I do feel like, let's put something out there and at least we can start a conversation, and hopefully it won't just be a flat out no, it'll be let's have a conversation. So know that there are areas and aspects, and there could be others working on some other things, but give my office a call. We're always happy to have a conversation with you and see what we can do. But I mean, the senator's right, the insurance industry is tough. They are tough.
Anybody else have any questions?
We're formulating our answer.
Yeah, I guess I was kind of going off of the comment I think you made, Senator Kearney, about fraud, waste, and abuse. And as someone who worked as a provider in community mental health, we talk about getting professionals into these jobs, and I don't think even the low pay is the biggest barrier. I think most people in those positions are there because of their hearts, not because of the paycheck. But I find the biggest issue to be like oversight from insurance companies, such as like MCOs, and then also just like this is where I don't know what my question is, but anything the government is involved in, I think about not just policy but like procedures, and like how so many of these systems are so complicated to navigate in terms of like if you want benefits, like applying, like I just for 10 years I've helped people navigate systems, and it's so hard to just do it in a way that feels efficient. And so I guess my question is, if people talk about that, and like how do we advocate for not even the policy to change these like the procedures and who's in charge of how it works to access these services, and like we talk about housing, education, black hole, that's the line that I see across all systems is like bureaucracy and just inefficiency in the procedures. So just any thoughts?
I'll jump in if that's okay. We do see that across the board, and it's part of like if you sit in my seat and understand sort of what it takes to actually do legislation in terms of the number of hoops you need to jump through, the number of, we're constantly talking about, how do you control unforeseen circumstances or things that what is this going to do this? Is the whack-a-mole thing going to work because you push something here and it happens over there? So there's a lot of really careful thought that goes into how these things are drafted. That being said, there's a fundamental understanding in Harrisburg that things are way too complicated and that we're doing, we're forcing to do things. And the governor's had an initiative over the last 2 years to really kind of try to streamline procedures. And a lot of it you see now is with things like permits, like how to get a permit to actually start a project or to do things that are different. And with the DEP and the Department of Environmental Protection and with economic development thing, they've reduced those things amazingly, and they've done it because they paid attention to it. So we need to do that across the board, and we need to try to make that happen. And again, it's if you leave Harrisburg up to their own devices, it won't happen because they're trying to be so careful about things. I don't think there's anything, criminal about it or vindictive about it or whatever, but it's just nobody wants to be in a position where, we didn't think of that. Is a result that happens from legislation.
Yeah, I would. I agree with you. I think some of it comes also from working in silos. So DOH working in one silo, DHS working in another silo. Like there's a lot of that, I think, amongst the agencies in many cases. And I think a lot of times, again, as legislators, we have in some ways created that. So Senator Carney's right. You try to look at everything and see what's going to happen. Where's the push and the pull and in some of this legislation, but sometimes in order to get something through, you need to put some sort of mechanism for tracking or mechanism for, to prove that the money, if we approve this and the money's going here, like how's it? So, and some of that is the way you have to get legislation passed. That would be the compromise. Whereas, like me, I'm like a bleeding heart. I'm like, we need to do this. We can do this. We can do it so easily. Let's just do it. It's so easy. And then there'll be others who will be like, well, you can't just give money and not know where the money's going, or you can't. So some of that is about, how do we get legislation passed? And then plus, and one thing I've learned, and again, I've only been in this job for 3 years, but there's legislation on top of legislation on top of legislation. We're going to open up Act 34 of 1972, and we're going to do this to. You laugh, but seriously, that's how some of this is. And when you do that, then sometimes you don't know that there's an unintended consequence later on down in the piece of legislation that you fix this little piece because you think you're fixing one thing, but then this other thing has gone a little bit awry. So it's definitely. It is definitely a challenge, but a lot of it is around how we get the legislation passed to begin with, to get the program or service going, and then how we are able to justify that service, that expense to those who might be a little doubtful to begin with.
Let me just jump real quick just to finish up a thought. One of the real, I think, troubling things that's happening in Harrisburg right now is that behavioral health, mental health issues have kind of fallen off compared to where they were 2 years ago, 3 years ago. Almost everything we were doing surrounded that idea. The amount of money that we were able to get to public schools, for example, to get more counselors in and to actually kind of deal with stuff. The Safe to Say program, which was originally meant as a way of trying to reduce violence in student violence in schools, really turned into 95% of the calls in the Safe to Say program were around students' mental health. And that really kind of was an eye-opener for us in Harrisburg as to the extent of the problem and how much we really should be paying attention to it. Now, with what we're trying to deal with the things that are coming out of Washington and trying to sort through everything from whether or not people can really be eligible to get food assistance, and and the like, I think has forced that sort of behavioral health, mental health piece. I don't want to say back burner, but certainly off the front, and that's a shame because that's I thought we were making some real headway and trying to literally get something done.
I know we need to be done with this question, but I was going to say the one thing I will say is when behavioral health services and things like that first started being covered by insurances, there was no like blueprint for how to do that, and that's where a lot of those things came from. Those like very like punitive measures and trying to really monitor it very, very closely because they didn't know what they were doing. But more recently, mental health parity got signed into law. And obviously it's a work in progress and it's not happening yet. But I'm hopeful that for people that have insurance, it is going to take some of those barriers away because now it has to match the access to healthcare services. So I do, kind of in a positive note, think that mental health parity is a great step in that direction. So hopefully we will see some of that go away because we have lived in that rough system for a really long time, and it would be nice for people to give us a break for a minute.
And one thing we were talking about before the start, I just want to point out, any funding that makes us accountable for outcomes but doesn't tie so hard to eligibility criteria is going to make a huge difference because we're seeing the huge barrier. Families can't get help from us because they can't meet the eligibility criteria. They completely have no income, but they can't document efficiently that they don't have income, and it's just a mess. So if we could just tie it more to the services that we then are able to provide and the outcomes that we get out of it instead of making it so hard for people to get it, we'll be better off.
Not a fully formed thought, but I feel like there's a through line between your question and your question about the narrow networks. And I think that there's this piece that comes up to me when we talk about funding. It's almost as if we're like so concerned about spending on healthcare as if that money should legitimately go somewhere else. And I think that when I'm talking about once we collectively decide that these are services and care that we all need, like all of us, regardless of underinsured, uninsured, or what, and then it kind of shapes the way that we provide and kind of regulate the care. I feel like so many of these obstacles are meant to keep people from services, and they shouldn't be.
Hello? Alright, there we go. Hi, I'm Amari. I'm 21. After hearing, you guys speak, the future of my healthcare is looking a little bleak, after I'm off my mom's plan, of course, but I've been dealing with these allergy medical issues for quite some time, and, I get these virtual appointments, but I'm not really feeling seen or heard. So how do you guys think I could advocate for myself or other people, young adults in a similar situation?
I don't even know that's such an important question. With your population of folks, did you want to say?
I was gonna say, I use your platform, man. Like, I just talk about it, put it out there, social media moves people, and like we were saying, like people have to keep talking about this. You just listen to us talk about it for almost 2 hours right now. The care isn't there, the access isn't there, and it doesn't seem like it's coming anytime soon. So people need to hear you. Post it, talk about it. Other people will relate to your experience, and that's the only way we're going to move people is if younger people start and communities start really saying something and like use the platform. Go for it. I support it. Tag me in it. I'll share it.
But hearing you say that today, that's actually really helpful as we keep having these conversations about rebuilding the healthcare ecosystem. It's like I just love that I heard that now because I'll have that in my head when we're talking about some of this stuff. So thank you.
I listened to your question as a mom, and I'm wondering, do you have a good primary care provider? I think that oftentimes we get out into specialty world, and primary care's role is to help you as an advocate as well. And I would say, get a primary care and like have that person help you figure out how to navigate the things that you need.
I would say don't be afraid to speak up, and don't, and don't be afraid to say, I feel like you're not listening to me. Let people know how you feel. Let your professionals know. And that helps them, I think, also then be better providers. So don't think of it as a criticism. Think of it as helping them to be better.
Amen to all that. I mean, the one thing I think it's important to understand too is that one of the amazing things about the Affordable Care Act when it was passed was that it precluded pre-existing conditions as a reason for denial of services. So as you're aging out of your parents and looking for stuff on your own, I mean, I think any work you can do now to try to make young people understand that how big a deal that was with the Affordable Care Act about pre-existing conditions and what it could mean for everybody, even for something like allergies, in terms of moving forward. All those things are, I think where we sit, or where I sit at least, probably Lisa too, but we think of your generation as a big question mark. We're trying to figure them out. We're trying to figure out what's going to happen. We saw the last presidential election. We were surprised at some of the demographics in terms of where people voted and how it kind of worked. And there were a lot of things at stake there that we could spend days talking about. But I agree about that. You do have a platform, and you have people willing to listen who are in positions that at least they have the years behind them to be where they are. So thank you for that.
Generations back to fix all the mess that we've made.
That's all the time, unfortunately, that we have for questions, but please, I encourage everyone before we wrap up to visit our tables, activities. Walmart's here, physical therapists are here, but also Pennsylvania Human Relations Commission, so much tied and overarched into potential discrimination. So please, we're a nonpartisan commission, and we do take complaints of discrimination based on disability and some of the other protected classes that we touched on today. So there's information at that table as well. But right now, I'd really just love to thank our host here that had us today, and please join me in thanking our tremendous panel. It was just an amazing day. Thank you. And thank you all for being here on a Saturday and giving us your time. And as I said, when I opened, we're here to listen, and you gave us so much to think about and to take back with us. So thank you all.